last talk, which is the eye trace or the ray tracing aberrometry for corneal and lens-based refractive surgery. So, essentially, this is what an eye trace looks like, and it has two major components. It has an aberrometer, and it has a topographer, and also it has an autorefractor and optometer. So this is what makes it so reliable and so good, because it gives auto refraction, it gives placido based corneal topography, it gives ray tracing aberrometry, it gives the pupillometry, it gives the keratometry in these patients. So the basic principle behind which the ray tracing works is that there are 64 shots fired in 4 rounds, which leads to 256 shots, and these sequential spots are they combined to form the retinal spot diagram and give us the point spread function. So since the patient is looking at a distant target with relaxed accommodation, the measurements are a lot more physiological than with other machines. Now, this is the problem with some of the more common aberrometers, which are using the Hartmann-Chack principle, or they are using the Schoening principle, or maybe the skioscopy. What happens is, like, we have lenslets and they fire a fixed signal into the eye. The signal comes out and we analyze that. Or what happens is, fixed spots are fired into the eye. They are analyzed once they exit the eye. Or in skioscopy, there's a broad beam kind of a pattern. But what happens, it leads to errors. There is something known as the crossover effect, or there is a duplication of points which are red, or some points are not red. So there are so many things by which uh, the ray tracing analysis is superior. This is more important not in normal eyes, but in eyes which have been operated, post RK eyes, post penetrating keratoplasties eyes, or patients of keratoconus, or some other things which are making the cornea irregular. This is where the eye trace really becomes so much more reliable than standard barometers. Now, if you look at the concept of this ray tracing, you will see that each of these rays is falling on a different spot on the retina. When it exits, it is being analyzed, and that is what makes it so special. It's one comment is that if you must take precautions when we are doing the ray tracing. The patient has to look through a target, through a distant target, and relax the accommodation. That's how you will get most reliable readings. Now, what can we use the eye trace for? We can use it for preoperative planning and cataract and refractive surgery, and we can also use it to decide whether does the patient need cataract surgery or not, and we can use it to diagnose any lenticular pathology in patients, and also to one of the ways to assess the visual outcomes both of cataract surgery, refractive surgery, or any other procedure. We can use it for toric IOL alignment, and we can also in case of post refractive surgery patients, use this machine to decide whether the patient needs an enhancement or not, or also whether the patient is a good candidate for multifocal IOLs or not. So, one of the programs that we use in cataract surgery is the topography and the aberrometry combined. Now, the most important thing here is that there is a data verification that we can do. We know that garbage in is garbage out, and that is where here it gives you at a glance how many spots have actually been registered, studied, and by the machine before the report has been given. So this is a quick assessment of the patient's visual system actually can be done just by looking at the verification display which is there in this machine. It also gives us the tracy refraction and the aberrometric summary of this patient. And tracy refraction is color coded. If it is green in color, it means that it is something that we can correct easily. However, if it is red in color, it means that either it requires a surgical treatment or a customized approach to rectify that particular problem. Now we have the wavefront display map, and so what it does is that if many times if you just look at this map, just look at this is a girl who had come for refractive surgery, and we can see by internal we mean this aberrations are actually limited to the lens or the lenticular system of the eye. So a green equal color is considered to be normal. If we see anything else that is variegated in appearance, has multicolors, rainbow colors, it's something is very wrong with the eye. So there's something known as the Chang analysis, and just at a glance, it quantifies the ocular aberrations in the eye of the patient. If you look at cataract in these patients, now this patient actually had been subjected to a CT scan. He said he had complaints of diplopia. He had a reasonably good vision, 6/9 vision, which was correcting to in both eyes. But when we take a close look at the map of the patient, it shows an opacity grade which is more than 2.5, and it also shows a DLI value. So these are the kind of gradings which are given on the eye trace. The DLI is also the dysfunctional lens index. Now, this is again, we really don't know exactly how the Tracy Technologies has developed this nomogram to calculate the DLI, but it relies on the natural aging changes of the lens, as well as the diminished optical performance of the lens, and possibly it correlates them with the higher order aberrations, visual acuity, and contrast sensitivity of the lens. So it uses certain parameters to give us one quantitative value that we can use and apply in a patient of cataract surgery. So a DLI less than 5 may be considered that the patient may be benefiting significantly if the patient undergoes a cataract surgery. This is not to be applied blindly on patients. There are errors like, for example, high myopia or other kind of lenticular aberrations. It will give a false kind of a reading, and we have to be very cautious while interpreting it. So if then we look at the corneal and the internal lenticular profile and the vision simulator of the patient. Now, if we look at the vision simulator, this is a very useful tool for us to educate the patient as to what they are having. So it shows us on an E, and it shows the kind of, for example, if we look at this patient, this is the corneal vision simulator. It shows the cornea is almost normal in this patient. It is the internal or the lens system which is more defective in this patient. So if we take a close look at the opacity grade in this patient, and sure enough, when you look at the Chang analysis, it shows that there is the cornea shows an astigmatism that can be easily corrected by refractive surgery and other toric IOLs or something. But if you look at the lenticular system, this patient had come to us for refractive surgery, and this patient had had a lens coloboma, which was the cause of her visual problems. Again, just to clarify this, look at the color patterns on a wavefront map. You will see a smooth green color. This is the cornea. It shows the cornea is normal. And if you look at the internal aberrations wavefront map, and you will see that all these kind of rainbow colors are there, and this indicates some abnormality is there in the patient. Now we have patients of posterior capsular opacification coming to us, and we don't know whether we should actually do the YAG. Is the patient going to benefit from a YAG capsulotomy or not, especially in earlier stages? So PCO like this, and in this patient, again, it shows that there is the DLI goes down, and it shows that maybe, and also we look at the opacity grade, and it shows that this patient is a good candidate for doing a YAG capsulotomy. In cases of scaled fixated IOLs, if the IOL is misaligned, it will show us the high grade of coma, that is the cause of the visual complaints. It also, in these kind of maps, it has this little spectacle mark. So it shows that what a patient, how he will see with spectacle correction. So in some of the situations, if we click on it and the vision improves, or the vision simulator shows an improvement, it means that just giving spectacles would be a good idea, and the patient might see better. Now, I will not go into this, but for toric IOLs, there are specific program designed for toric IOL, not only to align it pre-surgery, but also to check its alignment post-surgery, and also that to decide whether there is a significant amount of malalignment, and we need to undertake the surgery to correct the toric IOL alignment or not. Now, to decide whether, if there's some residual refractive error, sometimes we get patients who have very little residual refractive error, but they are highly symptomatic. We can't figure out what's wrong with this eye and how to go about it. So if you look, there's something known as the MTF, or the modulation transfer function. Essentially, it is It is a numerical value, or it's a chart along with the numerical value. It tells us whether what is the contrast of the or the visual quality of this optical system of the patient's eye. For example, in this patient, you will see in one eye, you will see that this is the map, the corneal map, and you can see here it is above this red box. Now, this red box is corresponding to 40% contrast and 10% 10 cycles of spatial frequency. So any line which is above that is considered to be good optics, and if the line is below that, it's considered to be bad optics, right? And such a patient underwent enhancement. We lifted the flap up and we just took care of the refractive error of the patient. And this is the image which is post enhancement. Patient was very happy with that, and we can see the changes in the slope of the MTF of this patient. So finally, cataract surgery, the bread and butter of so many ophthalmologists. There's so many things, ways in which an eye trace can help us, including alpha D, the MTF, the IOL selection analysis. So if we look, essentially, what is angle kappa? Angle kappa is the angle of the visual axis to the pupillary center, and angle alpha is the visual axis to the limbus. So angle alpha basically tells us how well the intraocular lens is going to be centered inside the bag once the cataract is out. And of course, that if it is high, it means that in premium IOLs or multifocal IOLs, or if there's a misalignment, the optics will not be good, and the patient will not be happy or a good candidate. So if you look at a simple algorithm for selecting the IOLs, we perform the eye trace, we assess the optical alignment with angle alpha and kappa. If the angle kappa is more than 0.5, we should go in for preferably a monofocal IOL. Or if the angle kappa is less than 0.5, then we can look at the Chang analysis if the corneal aberrations are less than 0.14 or more than 0.14. If there are significant corneal aberrations, we should again prefer a monofocal IOL and not go in for a multifocal or a premium IOL. In case the corneal aberrations are low, then we look at the IOL skin, see if the patient needs a toric IOL or not, and we can go in for premium IOLs in these patients. Just in order to make all this simple, they have given something known as an IOL selection analysis, and it says here: is the tracy refraction normal? Yes or no. Is the corneal higher order aberrations present? No. So this patient, and are the internal HO is present? Yes. This is because of the cataract. So it automatically gives us that we can go in for a premium IOL or not in these patients. So just to make the life simple for cataract surgery, cataract patients. So to conclude, a 2020 unhappy patient is unacceptable in the 21st century, and in this new era of cataract and refractive surgery, I think the eye trace is an invaluable tool, and this is not only for planning of the surgery but also to communicate with the patient, and to understand the outcomes of surgery, and also to assess our own outcomes, how we are doing in a better way. Thank you so much.